share with you clinical presentation and symptom overlap. So why is it important in the sense of symptom presentation? Because IBS per se, it's a symptom-based diagnostic criteria. So at the moment, the gold standard is still by the Rome 4 diagnostic criteria. As you know, you need to have recurrent abdominal pain that is related to change in the motion, whether in the sense of frequency as well as change in the form of stool, over past 3 months with the onsets of 6 months. In an international survey back in early 2020 plus, 2000 plus, so the factors that contribute to patients, the patients assume that pain is the most important one. Bowel difficulties associated with bloating as well, and of course they have a lot of impact, like limited the eating as well as activity, as considered the most bothersome symptoms for DGBI. In another Canadian studies that they involved 2,500 patients with the diagnosis of IBS using Rome 3 criteria. The most common IBS subtypes was IBS mixed type, followed by IBS-D and IBS-C. And of course, IBS, abdominal pain and bloating are the most common symptoms. Not only that, obviously, in the IBS-D patients, more of diarrhea predominant, IBS-C, more constipation symptom. Other than that, severe bloating, straining, and tenesmus are associated with patients with IBS-C. In contrast, urgency and incontinence are the most common and most bothersome symptoms for IBS-D predominant patients. So these are the symptoms that you should not overlook, because that might impact, if you don't address them, they might impact their quality of life as well as their condition or symptom improvement. Of course, as I mentioned earlier, the cardinal symptom at the moment, if we use the Rome 4 criteria, is abdominal pain that's related to bowel habit. Rome 5 will be coming up next year, but not to forget Rome 3 in the past, whereby they take recurrent abdominal pain or discomfort that is relieved by passing motions are the diagnostic criteria. Okay, later I'm going to tell you why to us Rome 3 might still be relevant in certain sense. Okay, just to define, how do we define the subtypes of IBS? Is mainly defined by the Bristol stool type. If the 25% of the Bristol stool type of a week that is more of constipation type 1 and type 2, then we will define them as IBS constipation predominant subtypes. On the other hand, those with more than 25% of Bristol stool types of type 6 and 7 will be classified as IBS D. Then the rest are IBS mixed or undefined IBS. A lot of symptoms of constipation, patient with constipation, not only complain of Bristol stool types. There are symptoms whereby, in the functional constipation classification, whereby straining, lumpy heart stool, incomplete evacuation, anorectal blockage, maneuvers, as well as infrequent bowel movements are part of the diagnostic criteria for functional constipation. So therefore, we don't underestimate the symptoms. So we have to ask these symptoms at the same time. We have done studies, and also many studies from the community as well as in the West and the East shows that doctors often think that Bristol stool types is important. The physicians think that infrequent bowel movement is the most important symptom to us. Whereas in contrast, the patients think that strainings are the most bothersome, are the most frequent symptoms, as well as manual evacuation are the predictors of poor symptom outcome. So these are the symptoms that we shouldn't overlook. In America, Canada, and UK, there have studies that shows that when we compare row 3 and row 4, if we use row 3 criteria, about 50% of them wouldn't fulfill the criteria of IBS. In the Indian and Bangladesh study, whereby they found that actually, in fact, if you just use the row 4 criteria, more than 50% of them you will not diagnose them as IBS, whereby your treatment will be limited. Patient may not be adequately treated. In our own study as well, whereby we compare row 3 and row 4. So in a primary care, whereby we interview 1,000 patients, and we found that if we use row 3 criteria, 4% of the population, 4% of the patients study population fulfill the criteria for IBS. If we use row 4, only 0.9% of them, 0.8% of them fulfill IBS, and many of them we classify into functional constipation, functional diarrhea, etc. So whereby if you fulfill the you look into the treatment, FDA recognized treatment options will be limited if we use the row 4 criteria in certain situations. We have also published a paper together with Professor Alex Ford, a multi-center study from UK. So we included about 133 population from UK and Malaysia respectively. We found that in UK, 70% of the patients with IBS diagnosed row 3 also fulfill row 4, meaning that they probably only 30% of them do not fulfill row 4 criteria. Compared to Malaysia, whereby less than 50% of our patients fulfill row 4 criteria, and many of them in the West, many of them have more severe IBS symptom severity. The higher the score, the higher the symptom it is, and more of them have limited activity, as well as anxiety and also somatoform symptom as well. So this shows that in Malaysia, maybe row 3 criteria, or in Asia, maybe row 4 criteria may be less sensitive. Row 3 criteria still have a role to diagnose IBS. That's why maybe the symptoms of abdominal discomfort that is related to passing motion may still be a relevant question to ask. Alright, not to forget, as we know, IBS per se do not cause mortality. However, they impact quality of life. They impact our activity of daily living. They affect our quality, affect our economy, working capabilities, etc. So important to ask about, how would they affect their life? A study of about 2,000 patients, they found that 8 days out of 30 days per month had affected productivity, and 1.5 days per month you have to miss school or miss work. That is really a significant amount. There will be a lot of economic impacts to the patient as well. More than 50% of them had complaint of bothersome symptoms. In terms of IBS-C patients, they report to avoid sexual activity, difficult concentrating, and feeling self-conscious. In the IBS-D, I'm sure many of your patients always tell us, many of my patients always tell me, they try to avoid places without bathroom. They want to come and see me, they have to sit in front of the toilet, because they have to wait to see the doctors as well. Difficult making plans, they want to travel, overseas, they want to travel to the family. It's difficult because they need to they have the urgency to go to the toilet. Avoid leaving the house and reluctant to travel. That's a problem to them. Precipitating factors also important. Just now Professor Luke also mentioned about the pathophysiology of IBS. So many of times, Usually we should ask also about what are the possible factors and risk factors, for example, like infectious enteritis. Because sometimes they might make a bit of difference. Treatment with probiotics, rifaximin might be a bit more helpful than the other treatment. Stress important. Anxiety, depression are important as well, because if you don't address it, you'll keep on driving the bidirectional gut-brain interaction dysfunction. Sleep is also another problem. Some of my patients, when I treat, the visceral hypersensitivity, take into consideration some neuromodulators that might have the impact of sedative effect. Once they have the sleep, improvement, part of the symptoms improve. So psychological comorbidities are important. Meta-analysis of 73 studies shows that anxiety symptoms are very common. Anxiety disorders are also present. Compared to the healthy subject, the odds ratio of anxiety symptoms and anxiety disorder are more than 2.5 to 3.1. In terms of depression, also not low. So about 30% of the patients has depression symptoms and also depression disorder. The odd ratio compared to healthy control is like 2.7 to 3 times. That's a huge number. Back to our studies, we also found that not only UK population from Malaysia also suffer from anxiety. Hardly any one of them are normal. Less than 50% of them do not have anxiety. That's a lot. Alright. In terms of depression symptoms or borderline depression, actually Malaysia has more patients with IBS has more depressive symptom or depression disorder compared even to the UK population. So don't underestimate the presence of psychological comorbidities. Extraintestinal symptoms also, I'm sure many of your patients will always complain to you. They pain here, pain there, everywhere also pain. So usually we will have to, pay attention to them, listen to them. Back pain, arm pain, joint pain, everywhere also. There will be a lot of symptoms, psychosomatoform symptoms as well. Of course, we have to try to address it, make sure it's not the organic disease that's related to it, reassure them if it's not. In my second slide, whereby I mentioned that the diagnosis onset should be 6 months, the symptoms, right? Sometimes it's not practical in our sense, like we are seeing our day-to-day patients, clinical practice. Patients can't be waiting for us for 6 months before we start to diagnose them with IBS. We can't be waiting for 6 months before we start the treatment. The Grossman and also Professor Yan Tak, they have come up with a statement and recognize that Rome Foundation also recognize that in a clinical practice, of course in study ideally you should wait for the 6 months onset, but in clinical practice they recognize that shorter duration up to 8 weeks, you could potentially treat them as a DGBI and start the diagnosis and treatment, provided that you have a clear clinical confidence that the diagnosis is confirmed and without the organic GI disease. Next, I'll be covering about symptom overlap. Symptom overlap, in many studies, they show various results, but generally they are common. Okay? A meta-analysis of 46 studies involving 75,000 patients, the full prevalence of overlap syndrome is high, up to 36.5. In the tertiary settings, it's even higher, 47.3% compared to the population community-based setting, whereby 36.5% of them had overlap syndrome. Overlap, in other words, means IBS, overlap with functional dyspepsia, or other disorder of gut-brain interaction. So of course, overlap syndrome has consistently shows that quality of life, whether the component of physical, mentally are impaired compared to a single DGBI condition. They have more symptoms of anxiety as well and depression compared to the single DGBI condition patient. An internet studies of 26 countries involving 50,000 patients that shows that bowel disorders are things like functional constipation, IBS, gastroduodenal, for example, functional dyspepsia, anorectal like incontinence, dysphagia, esophageal disorder like functional heartburn, etc. So they found that a lot of overlaps among the four distinct region disorder. Okay? Among them, bowel disorder is the majority. This study also shows that if you have more overlap in terms of the regions of BGBI, the more overlap, the more severe the IBS symptom, the more severe the somatoform symptom, as well as depression, anxiety, more impact quality of life, and healthcare utilization in terms of mean number of medication and doctor visits. Our studies published in the NMO also shows that overlap syndrome were associated with poorer symptom outcome. This is a longitudinal study whereby we follow up the patient for up to 3 years, whereby we find that following treatment, overlap syndrome patients, lesser of them had symptom improvement, about 36% compared to those without symptom improvement, whereby majority forms the overlap syndrome patient. This multi-center study in tertiary center shows that in IBS patients, many of them have upper GI symptoms, in particular symptoms of postprandial fullness, belching, regurgitation are the most prevalent. Functional dyspepsia is the most common overlap syndrome, followed by belching disorder, functional heartburn. So these are the breakup of the symptoms that is associated with functional dyspepsia and IBS overlap. So in that same study also they found that protein was a risk factor for IBS and FD overlap. So it means that in patients with IBS, they complain of a lot of bloatedness. Don't forget to ask about functional dyspepsia. But by default, you should also ask about all these overlap syndrome, because if you just address the IBS, you forgot to address the functional dyspepsia, the symptom will not be adequately improved. The quality of life cannot be improved subsequently. In this study also, they shows that in PDS, IBS overlap patients, many of them are associated with IBS with constipation type, whereby in IBS-D and also IBS-D patients, they have EPS and IBS overlap more. So this systematic review also found shows that in the Asia population, the IBS-FD overlaps are not uncommon. They are common, range from at least 11% to up to 30% or even more. So ladies and gentlemen, in summary, for symptoms and overlap syndrome symptoms, the important we have to get an IBS focus history minimum with this. We want to know the typical cardinal symptom and all other GI-related symptoms as well. Not to forget about the duration of symptoms, these factors, psychological comorbidities, extraintestinal symptoms, and ask about all the other functional GI symptoms as well as medication. This you can find it from the BSG guidelines for IBS. With that, I would like to thank you for your attention.